As already mentioned in the previous lecture, the inflammatory response demonstrates local consequences together with some systemic effects. The systemic effects include fever response, which is due to the massive release in severe inflammatory response of cytokines acting as pyrogen into the remote site hypothalamic regulatory centers. So, this is a remote effect due to excessive release of pyrogens, the interleukin-1 and tumor necrosis factors. Another remote effect, this is the sleep disturbance, sleepiness observed, also suppression of the appetite. This is an effect of the tumor necrosis factor on hypothalamic satiety center, weakness, weight loss, and some effect concerning the local lymphatic system reactions, such as lymphadenitis, lymphangitis, and sometimes even bacteremia. Bacteremia is due to the passing of bacteria into the blood, thus the infection spread into the body, causing eventually a sepsis. Sepsis is characterized by dramatical changes due to the excessive release of inflammatory mediators. This slide illustrates the consequence of a sepsis due to excessive release of endotoxin, causing generalized effect, already mentioned fever into the hypothalamus, but also changes into the breathing and cardiovascular function, changes into the intravascular volume, causing eventually shock, and finally cellular hypoxia with generation of toxic radicals, acidosis, and multi-organ dysfunction, causing eventually death. Another characteristic of the inflammatory response, this is the release of acute phase proteins, the generalized consequence, such as C-reactive protein, serum amyloid A, and fibrinogen, among others. These proteins play a role to help the cells to clear damaged proteins or to restore slightly damaged intracellular proteins. Good. Now, inflammatory response. Is it necessary to try to suppress at least sometimes the inflammatory response? Let's consider the consequences of the acute inflammation. We have beneficial effects from the exudation and phagocytosis. However, in the same time, there are some undesired effects. So, if the pain is intensive and prolonged, it is advantageous to block, at least at some extent, the inflammatory response. Or, if the swelling is so great that it impairs functions, for example, limiting joint mobility or obstructing some anatomical passage, for example, compression by the swollen pancreas in acute pancreatitis of the common bile duct. Tissue damage may be observed, for example, in glomerulonephritis, prolonging and complicating the local changes. Thus, at least at some occasions, we may apply anti-inflammatory treatment. How? Drug therapy is used to block the release or the effect of mediators of inflammation, for example, antihistamines. They will block the H receptors, or non-steroid anti-inflammatory drugs to block cyclooxygenase activity and thus the prostaglandin synthesis. This will reduce vasodilation and swelling due to the suppression of the vascular permeability. And finally, steroids. Steroids block the release of arachidonic acid from inflammatory cells. Thus, they reduce both the prostaglandin and leukotriene synthesis and limit the swelling and the damage from the phagocytes. Also, the steroids stabilize the lysosomal membranes and limit the enzyme release and thus the tissue damage. Sometimes the acute inflammatory response is unable to remove or to neutralize an injurious agent, and sometimes prolonged duration of the effect of the exposure of the factor is also observed. So, to remind, the acute inflammation its duration is about 2 weeks. The chronic inflammation duration exceeds 6 weeks and sometimes even months and years. In chronic inflammation, alteration, destruction, and attempts to healing are proceeding simultaneously in the same time and the same place. So, let me note that in the acute and even in subacute inflammation, the fluid exudate predominates, but it starts to diminish in significance, while the cell response in subacute inflammatory response assumes domination. And finally, in chronic response, in chronic inflammation, there is a standoff between the attack and the injurious agent and the counterattack mounted by the defenses of the host. The antigen is not cleared, the causative agent is not clear. Instead, it persists and will cause later long-term inflammatory reactions with the participation of mononuclears. How is the chronic inflammation born? It may arise in several ways. First, it may follow an acute inflammation, so it is caused by the well-known factors. Necrosis, for example, due to infarction, or exogenous factors such as infections, toxins, trauma. And the local changes are the well-known vascular changes, cell changes, and they are regulated by the release of inflammatory mediators. Sometimes the chronic inflammatory response may result from repeated bouts of acute inflammation. In other cases, it begins as a low-grade response that does not follow the classic acute inflammation characteristics. So, it may be due to persistent infection by intracellular microbes, for example, Mycobacterium tuberculosis. In other cases, the chronic inflammatory response is caused by prolonged exposure, as shown here, to non-degradable potentially toxic substances. For example, deposition of dust, silicium or asbestos into the lung will produce chronic inflammatory disorders known as silicosis and asbestosis. And last but not least in order of importance, immune reactions, deposition of immune complexes, antigen-antibody, especially in autoimmune disease, will cause a chronic inflammatory disorder. Which is the characteristics of the pathogenesis of the chronic inflammation? First, infiltration with mononuclear cells. This is the typical characteristic, together with progressing tissue destruction and connective tissue replacement for the parenchymal cell loss. The mononuclear infiltration is due to the presence of macrophages. They are the central figures in the chronic inflammatory mechanism. they secrete a number of biologically active products, and they derive from the peripheral blood monocytes that have been induced to immigrate across the endothelium by some chemotactic agents. The most important chemotactic agent, this is the monocyte chemoattractant protein 1. This is a cytokine. Also, fragments of the complement system, especially C5a, also fibrinopeptides, collagen and fibronectin fragments, among others. In the interstitial space, the immigrating monocytes are converted to tissue macrophages and later activated by two main mechanisms. Immune mechanism by activated T cells releasing interferon gamma, an important cytokine, or non-immune by factors released by local intruders, for example bacteria producing endotoxin, a powerful activator of the tissue macrophages, and also some metabolic products and chemical mediators. The activated macrophage produces a lot of active substances, for example neutral proteases, arachidonic acid metabolites, growth factors, cytokines, especially interleukin 1 and tuberous necrosis factors, but also coagulation factors, nitric oxide, among others. Which are the direct consequences of the macrophage's activity? They will induce profound tissue change, tissue destruction, especially by the proteases and the toxic oxygen metabolites, and will cause connective tissue accumulation, fibroblast proliferation, collagen deposition, fibrosis with remodeling of the area affected. In addition to the monocytes, macrophages, other cells also participate, for example lymphocytes. Lymphocytes are mobilized by antibody and cell-mediated immune reactions. They are activated by contact with an antigen, in that case presented by an activated macrophage, and they will produce lymphokines, especially interferon gamma. This cytokine will activate other macrophages to convert them into activity and to extend the chronic inflammatory reaction. Also, the activated lymphocytes will produce also other inflammatory mediators. Plasma cells are also participating into the chronic inflammatory process, especially by producing antibodies against the foreign antigens and against the altered tissue components. And finally, eosinophils in immune reactions, they are releasing by degranulation the so-called major basic protein, a highly toxic substances, for example for parasites. However, this substance will cause also lysis of host cells. Thus, the tissue destruction is the characteristic of the chronic inflammation. It involves both parenchymal cell and stromal network destruction. The restoration of the damaged tissue cannot be accomplished solely by regeneration of parenchymal cells. It involves replacement by connective tissue, fibrosis, and scarring. Formation of new blood vessels, angiogenesis, and remodeling, maturation of reorganization of fibrous tissues are also observed. Now, which are the forms of the chronic inflammation? Most commonly, the chronic inflammation presents as a non-specific chronic inflammatory reaction? A diffuse accumulation of macrophages and lymphocytes at the site of the injury. In a lot of cases, however, it may demonstrate under the form of granulomatous inflammation. A specific lesion, granuloma, is formed. A typical evolution of a granuloma is shown here on the slide. The granuloma represents a nodular collection of modified macrophages with abundant cytoplasm, epithelioid cells. These are the modified macrophages, epithelioid cells. They may coalesce to merge to form multinucleated giant cells. The giant cell is another characteristic cell Langhans type of the granuloma, chronic inflammation. A typical example of granuloma, this is the foreign body granuloma. It is elicited by relatively inert bodies surrounded by the granuloma. Immune granuloma is formed by immune T-cell mediated response to poorly degradable antigens. Lymphokines, especially gamma interferon, are causing transformation of macrophages to multinuclear giant cells. Characteristic granulomas are observed in several diseases, especially in tuberculosis, sarcoidosis, silicosis, among others. Let's now summarize the mechanism, the pathogenesis of the chronic inflammatory response due to the persistent inflammatory stimulus. Long-term activation of macrophages and lymphocytes accompanied by release of growth factors, cytokines, and decreased metalloproteinases. The growth factor activity will cause proliferation of fibroblasts and endothelial cells, angiogenesis, while cytokines will interact with the increased collagen synthesis and thus to cause deposition of collagen fibers. Fibrosis. Fibrosis, this is the hallmark of the chronic inflammation. How is it possible to evaluate and make a prognosis about the outcome of a chronic inflammatory response? If the stimulus is removed, regeneration or healing by scar formation may be observed. However, in persistent tissue damage as observed in chronic inflammation, fibrosis with tissue scar formation is unavoidable. Chronic inflammatory diseases are characterized by fibrosis, for example, cirrhosis of the liver, pulmonary fibrosis. Let's analyze the cell response. Necrosis caused in chronic inflammatory response may be complete, no surviving parenchymal cell, so scar will be formed to repair. Partial necrosis, if present, the response will depend on the cell type of the area affected. Labile cells, as an example, epithelia, are able to regenerate. Stable cells, for example, hepatocytes, are able to regenerate if the connective tissue framework is intact. However, if the connective tissue is affected, repair will be done by scar formation as observed in chronic inflammation. And permanent cells cannot restore by regeneration. The repair of such an organ, for example, the heart muscle, is done by scar formation. Let us now pay more attention to the healing, both after chronic inflammatory responses and after other damage types. The healing is defined as the ability to replace lost tissue, restoring structure, strength, and sometimes function. The acute inflammatory response provides a transition between injury and healing and overlap between the two responses. The replacement is achieved by proliferation of adjacent undamaged tissue. Parenchyma, these are the characteristic functional cells in an organ, which are bound together and supported by stroma, are subjected to regeneration or to replacement by connective tissue. The stroma represents the combination of the connective tissue and the blood vessels surrounding the parenchymal cells. The force of healing, as already mentioned, may be due either regeneration or repair. The gap left by the loss of damaged tissue is filled by a fibrous scar. Which are the components of healing? Tissue replacement, either by regeneration or repair, is accompanied by revascularization, formation of new vascular channels, and later by reepithelialization, re-establishment of protective epithelium of injured body surfaces. The regeneration, let's comment very briefly, is typically observed in labile tissues, less commonly in stable tissues, and never in permanent tissues. The repair, this is a process of laying down fibrous connective tissue to restore the strength and structural integrity of damaged tissue that cannot regenerate. So, this collagen-rich replacement tissue represents the scar. The scar is formed by the process of fibrosis. Let's now consider the collagen fibers formation. This is the principal event in fibrosis. Fibroblasts, these cells are normally present in the connective tissue of the organ stroma. Fibroblasts, they are resistant to damage. They survive and initiate repair. In addition, fibroblasts are able to migrate to the adjacent areas. They are producing procollagen, the fundamental subunit secreted outside the fibroblast. Long filament formation follows from the tropocollagen, and thicker collagen fibers are produced later. Collagen fibers bundles, this is the end stage, together with cross-linking with newly formed collagen fibers. This cross-linking will increase the tensile strength. The sequence is illustrated here. Fibroblast presence, procollagen production, filament deposition, collagen fibers assembling, bundles formation with reorientation along the stress lines, and finally increased tensile strength. Also, collagen fiber will form additional chemical crosslinks, additionally increasing the tensile strength. This is illustrated on this slide. The collagen content is increasing initially together with the increase in tensile strength. However, later it stops to increase. Despite that, the tensile strength continues to increase due to the formation of chemical links. This is the characteristic, the increase in tensile strength of the repair by fibrosis. Let me stress again that the bundles realign along lines of stress. Intercellular matrix is formed by the exudate of the acute inflammatory response. Fibroblasts form collagen and also proteoglycans, thus deposition of matrix and scar development. Sometimes clot may be formed because of vessel disruption. Fibrin formation, a mesh enwraps blood cells and tissue debris, adding to the scar formation. The organization in that case includes elimination of the clot by phagocytosis and its replacement by scar tissue. The healing of some cell populations depends on the status of their basement membranes and the underlying intercellular matrix. For example, in respiratory epithelium, basal membrane and the intercellular matrix lost, this will cause a scar formation and functional loss. While if basal membrane and the matrix are intact, a full regeneration with restoration of functions are fully possible. And let me to stress again especially on the role of the extracellular matrix. Injury to a labile or a stable tissue will depend on the undamaged extracellular matrix. If undamaged, regeneration with restoration of function is present. If extracellular matrix is damaged, repair but function will be lost. Repair by scar formation. Necrosis because of injury to a permanent tissue, also the repair is done by scar and the function will be lost. Let's now comment an important aspect of the healing, the revascularization or the angiogenesis, production of new blood vessels to supply and drain the damaged site. The revascularization starts with the formation of a loosely gelled, protein-rich exudate, and later by the formation of granulation tissue. Subsequently, formation of new capillaries from intact vessels. First, a butt arises from normal endothelium adjacent to the damaged site. Later, merging and formation of new channels by merging with another butt. The re-establishment of lymphatic drainage follows. However, it is starting later and it is slower as compared with the blood vascularization. The final change includes a reduction of vessels number because of the decreased metabolic demands with healing completed and at the end growth of vasomotor nerves, both vasomotor neurons, months after the new vessels formation. Thus, the revascularization is complete. The revascularization is followed by reepithelialization. The reepithelialization starts by the development of active mitosis zone. Later, cell migration of newly produced cells is observed, and basement membrane formation secreted by the migrated cells. Cells anchoring on the basal membrane is observed, and finally movement up to fill the hole caused by the damage. In the end stage of reepithelialization, specialized cell types lost are replaced. For example, hair follicles and sweat glands. Let's now consider the mechanisms of wound healing. As an example given, the skin. The wound healing may be primary or healing by first intention. An example for such a healing is the clean surgical incision. It represents a wound with good apposition, closely apposition of the ends. The healing starts by a blood clot formation. During the first 24 hours, neutrophilic cells infiltration and mitosis appear in epithelial cells. Closure will take place within 24 to 48 hours. In day 3, neutrophils are replaced by macrophages and granulation tissue appear. Revascularization is starting, and the clot is now converted to a formation known as scab. After the 5th day, granulation tissue is present, angiogenesis is maximal, and collagen fibers appear, collagen deposition. Epithelial proliferation is present and will continue. During the 2nd week after such a damage, fibroblast proliferation is present and scar formation because of the collagen fibers accumulation. Scar tissue is formed. There is no signs of inflammation. There are no signs of inflammatory swelling, and new vessels are present. Now, this is an example of secondary healing, healing by second intention. It occurs when there is a more extensive loss of tissue, large wounds, ulceration, abscess formation, infarction. The wound edges are not closely opposed. The healing of such a wound takes longer, demonstrating with abundant granulations and wound contraction after the formation of the scar. The defect restored is markedly reduced from its original size. This is due to the contribution of myofibroblasts. They present contractile capability. The origin is not fully elucidated. This slide summarizes the wound healing after an injury, including the initial inflammatory change, the epithelial cell restoration, the fibroblast production, the contractile mobility, and the collagen synthesis to form after remodeling the scar. The healing process is under regulation of several hormones and cytokines, regulatory factors. The most important among them are shown here: the epidermal growth factor, platelet-derived growth factor, transforming growth factor. Especially the transforming growth factor B is inhibitory, not stimulatory. The interferon alpha is also inhibitory. All others are stimulatory, including the well-known interleukin-1 and tumor necrosis factor. The healing in other tissues, as compared with the skin, demonstrates some specific feature. For example, the bone healing is accompanied by the formation of so-called osteoid and hard callus. The regeneration of a neuron is a long process. After damage, first debris are cleared, myelin debris are cleared by phagocytosis, and later myelin sheath is restored and regeneration is complete. This will take many weeks. It will take many weeks or even months. Now, it is necessary to comment some complications of the healing. For example, contracture. When damage is extensive, newly formed collagen demonstrates an exaggerated contraction as it matures. This is here an example of contracture following a large burn. The contractures present some complications. For example, there is a mobility limitation because of the close proximity of a joint. Sometimes distortion of adjacent areas, for example, disfiguration of the face may be observed. Another complication, this is the stricture. Stricture, this is the contracture of a scar tissue in repair to damage to the walls of tubular organs, narrowing of the lumen. This will cause several disorders. For example, slowing or stopping of normal organ motion, infection, especially in the intestine, with complications up to perforation, or sterility if present in fallopian tubes, following, for example, venereal diseases damage. During the repair of serous membranes, which normally move freely against each other, adhesions may be observed. The organization results in a firm union of the two membranes, so movement restriction will be present of the heart, of the lung, in the intestine. Adhesions usually as a consequence of chronic inflammatory disorder. Another complication of the healing, this is the dehiscence, a rupture along a surgical incision, breaking open of a healing wound. Increased pressure is usually applied to healing tissue, cough, vomiting, diarrhea. Which are the risks? Infection, of course, and also at some occasions herniation. A loop of intestine is squeezed and compressed and eventually will necrotize. Keloid is another healing complication. It represents an irregular mass of scar tissue that protrudes from the surface of the skin. It results from the overproduction of dermal collagen during healing. This is due probably to excessive release of a particular growth factor known to promote fibroblast proliferation. Anyway, the exact pathogenesis of the keloids is not yet fully elucidated. They should be subjected to additional treatments, surgical treatment, to eliminate the excessive mass. Another healing defect, this is the proud flesh. It represents an excess of granulation tissue that protrudes from the wound to interfere with the reepithelialization, exuberant granulations. This is the typical characteristic of the proud flesh. The exact mechanism, the pathogenesis of this disorder is not yet elucidated. Most probably, the mechanism is related to a defect in the contact inhibition. Here, the mechanism of contact inhibition is demonstrated. After a damage, the growth of two subpopulation of cells is inhibited after the contact being realized. The contact in cells release inhibitory factors stopping further the migration of cells, mitosis and migration. However, if defective, the contact inhibition, this will allow these cells to overgrow and to form such a formation. Most probably this defect is due to some change, atypism of the cell types, because different cell types do not realize contact inhibition as shown here. One more healing defect, these are the Suture Complications. Keratin from the epithelium, which is normally restricted to the skin surface, is sealed within the suture tract deep into the dermis. Thus, it causes most prominent scarring. Finally, let us summarize some requirements for healing. The first one, this is the immobility, to not overload the organ or the extremity or the area. Next, adequate blood circulation, absolutely necessary. And third, supply of nutrients, especially nutrients containing methionine. Methionine is required for the production of proteoglycans in forming the new extracellular matrix. Let me remind the importance of the matrix in the regeneration and healing by restoration of the parenchymal cells. Also, zinc supply is important, especially for the matrix formation, and vitamin C, last but not least in order of importance. Vitamin C is absolutely necessary for fibroblasts to produce procollagen, thus to restore the damage to the matrix, producing normal connective tissue.